Yes. We got outline of benefits and when to do, when not to do both medical and radiation. It is very rare to find somebody who has done both, taken time and have patience to complete both the specialization. It's good to get somebody.
Thanks for the introduction, sir. So as sir said, I was previously a radiation oncologist and then I switched over to medical oncology. So today's class I will be speaking a bit about radiation oncology and medical oncology in general. It's impossible for me to give a detailed explanation of everything, but my goal is to at least get you acquainted with what we do. So how do we treat cancers? The various ways of treating cancer is that we have local and regional modalities, namely surgery and radiation therapy. Why are they called local and regional? Local because we address the tumor there, and regional because the regional lymph nodes are also addressed. And systemic modalities, here is where medical oncologists come in. We take care of chemotherapy, immunotherapy, targeted therapies, and hormonal therapies. So by default, everybody thinks medical oncologist only does chemotherapy, but that is one of the things we try to usually avoid. So the surgical goal is to remove all malignancy and tissues which could potentially contain malignancy. This is important. Not only try to remove the tumor, but also the locations where there could be potential spread. And in radiation therapy, the goal is to irradiate the tumor as well as the potential locus which could be containing any tumor tissue, microscopic or macroscopic. And chemotherapy is a loose term. Any therapy which uses chemicals is called chemotherapy. So technically, even anti-tubercular therapy is also called chemotherapy only. But cancer chemotherapy focuses on causing DNA damage or to interfere with DNA replication and thus kill cancer cells and prevent them from replicating or both.
Radical message can be ultra radical, including every other structure. Those are the days when the cancer was thought to be a local disease. Then they thought it may spread to regional tissues like extended surgery. As and when the concept evolved and you realize that it is a systemic disease, that's when the need for chemotherapy in the golden days is then progressed to immunotherapy, targeted therapy. Now we all accept that cancer is a systemic disease. Hence, you have to combine the local treatment with surgery, radiation, along with systemic therapy in most cancers. That's where this giving you the details.
That is the main mode of action. We will come to it in the coming slides. So, when I speak about DNA damage, what about the DNA damage which happens to non-cancerous cells? So that is where the concept of differential for repair comes in. So when 100 cancer cells and 100 normal cells are equally treated with chemotherapy, the cancer cells have a lesser ability to repair themselves from the DNA damage, whereas intact normal cells have good machinery which will repair DNA damage. So if 90% of the cancer cells die, 10% of the normal cells also do suffer. That's how it is. So do we have to go to the classification of chemotherapeutic agents? I think it is important for medicine residents, but for surgical residents, I think you should know a bit about it. Like the major classes: antimetabolites, alkylating agents, topoisomerase inhibitors, antibiotics, anti-tumor antibiotics, mitotic inhibitors, corticosteroids, nitrosoureas, and other agents. So I'll make it easier here. Antimetabolites are those drugs which interfere with cancer DNA synthesis and replication, such as methotrexate, we have 5-FU and 6-mercaptopurine. They interfere by causing defective DNA synthesis and thus lead to cancer cell death. Platinum analogs such as cisplatin, carboplatin, oxaliplatin, they cause direct damage to the DNA. And antimitotics, These interfere with the process of mitosis. We know the cell cycle has various phases, G1, G2, S and M1. These interfere in the mitotic phase. And anti-tumor antibiotics, again, they affect the DNA directly. And alkylators directly cause DNA cross-linking and damage. So the class examples are for antimetabolites, we have methotrexate, 5-FU. For platinum analogs, we have cisplatin, carboplatin. For antimitotics, we have vincristine, paclitaxel. And for anti-tumor antibiotics, we have D-actinomycin. And for alkylators, we have cyclophosphamide, temozolomide, and other drugs. It is important to know that there are a few other therapies which are sometimes classified as chemotherapy. For example, bisphosphonates. Bisphosphonates are basically used to strengthen the bones and prevent bone metastasis progression. And we also have hormonal therapies and targeted therapies which are sometimes classified as chemotherapy. So what is hormonal therapy? Certain malignancies are sensitive to certain hormones. For example, certain types of breast cancer, not all breast cancers, are reliant upon a significant amount of estrogen and progesterone for them to be able to sustain their growth and replication. And then we have prostate cancer, which is the other malignancy, which is very hormone sensitive, which is again dependent upon androgens. So when we treat these hormone sensitive malignancies, again, hormonal therapy need not always be medical. There are surgical ways of dealing with hormonal therapy. For example, oophorectomy and orchidectomies are the gold standard of hormonal therapies even today. Because once we do an orchidectomy, we can be assured that there is no more source of testosterone in that particular man. And for oophorectomy, it's not so perfect. When we remove the entire, both the ovaries, there is still a source of estrogen production, mainly from the adipose tissue. So in addition to that, we'll also require other medicines. Coming to medical hormonal therapies, we have GnRH, that is gonadotropin releasing hormone agonists and antagonists. When we use high dose of GnRH analogs, it's going to cause negative feedback in the pituitary and thus lead to reduced production of estrogen and testosterone in women and males, men respectively. We also have GnRH antagonists, which directly block synthesis of GnRH analogs. We have estrogen receptor modifiers, such as modulators, such as tamoxifen. We have inhibitors, such as fulvestrant, and we have aromatase inhibitors, such as anastrozole, letrozole. And we have other drugs, such as abiraterone, which are used in PC.
GnRH analogs. Is there any way of, for example, there are many people who tend to do very well, whether they had orchidectomy or prostatectomy, and if at all you are treating already a metastatic prostatic cancer. Just looking an example. Many of them, you give them GnRH analogs, and they tend to do very well. And some of them, there is despite GnRH, they progress. Is there any way of knowing which patients will respond and which who don't?
So in general, we start off with GnRH analogs and later see who is going to respond, who is not going to respond.
No, instead of identifying, because some of them, one of the surgeons I know who very good plastic surgeon recently expired, and he was on all these things. He had a radical, this robotic prostatectomy and everything still they progressed very badly despite being on this. So the problem is if there is no way of identifying new response, then you may take other paths rather than going down this.
Only about 5% of prostate cancers are not hormone sensitive. For example, they could be driven by other mechanisms such as BRCA mutation or some other mechanism. And they may have a neuroendocrine characteristic, they may have small cell characteristic. Usually when we look at the histology, when we see the typical prostatic adenocarcinoma, they are more likely to respond to these therapies. But the important question is for how long they are going to respond. Usually everybody is going to respond for a couple or more years. But what we do next is more important. But when we have a very high disease burden, we already know that we require quicker responses because hormonal therapies are not very fast in the responses. That's when we also had chemotherapy additionally. When we anticipate we need quicker response, we had bisphosphonate, for example, when we have extensive bony metastasis, and we may have focal radiation therapy when there is symptomatic metastasis. But for your question, sir, there are mechanisms which may preclude the response to hormonal therapies, mostly BRCA mutations and neuroendocrine features, for which there are mechanisms. There are investigations such as genomic testing, which are usually extremely expensive and not very cost effective.
Practical. Okay. It is for the resident this information in the good olden days during our training and before to that. Whenever there is a surgery for serious aspect, they also used to open the abdomen into biology. That is the standard of care. And a CFO state with metastatic. The standard of care was architecture. You guys know what's the difference between architectomy for the tumor or architectomy done for the CFO state? Is there any difference? Heard of the concept of consular architecture? Beautiful. Thank you.
And targeted therapies are another newer therapy wherein we target a particular molecule on a particular protein or an oncogene product on a particular cancer. For example, if the malignancy is overexpressing epidermal growth factor receptor, we are going to use a monoclonal antibody against this particular receptor, or we could use a tyrosine kinase inhibitor against this receptor. For example, we have a HER2 expressing breast cancer, where we target it with trastuzumab or trastuzumab conjugated with DM1 or some other tyrosine kinase inhibitors such as tucatinib. Then the other targeted therapies VEGF inhibitors is vascular endothelial growth factor inhibitors such as bevacizumab, which are used to prevent angiogenesis in certain malignancies. The targeted therapies are in a way effective, but with less side effects because they only target that particular target. But there is a problem with target therapies. Not every malignancy will respond to targeted therapies. The expression of the target may be heterogeneous. Sir has a question.
Sorry, the only reason I interrupted you, just wanted to know, specifically colon cancers. Is there any mechanism, for example, by colonic biopsies or colonoscopic biopsies, you are able to say whether there is expression of VEGF or related with derived growth factor or even endothelial growth factor? Because then you can straight away go for either trastuzumab or bevacizumab or things like that. In addition to FIFU and maybe oxaliplatin, rather than waiting for later date when the disease might have spread.
So colorectal cancers are usually curable in the early stages when they are not metastatic without the use of targeted therapy. A good surgery gives a 60 to 70% cure rate, and whatever we add additionally is a bonus. For example, with the use of proper surgery alone for colon cancers, the cure rates are 65%. With the addition of 5-leucovorin, the cure rate goes up to 80%. With the addition of oxaliplatin, goes up to 84%. But beyond that, whatever we do, it may not incrementally increase so much. But these targeted therapies are more useful in metastatic settings. For your question, there is a difference between right-sided and left-sided colon malignancies. Usually the left-sided malignancies and rectal malignancies do well with cetuximab and panitumumab, whereas the right-sided malignancies usually do well with bevacizumab. The other way of looking at it is the right-sided malignancies are more likely to be KRAS NRAS mutant, whereas the left-sided malignancies are less likely to be mutant. So these days we don't look at right versus left. We actually do the mutation testing. We look for KRAS NRAS mutation. If they are mutant, then EGFR inhibitors will not work. That's a inverse surrogate. That's all we look for. We don't look for actual EGFR expression in this. We look for any KRAS, NRAS, and PRAF mutations. If they are positive, then it's unlikely to work. And we also do next generation sequencing where we also look for other rare mutations such as HER2 in colon cancers. We sometimes do get that also. Recently, we had a lung cancer patient in whom we had a HER2 mutation, which sir has operated. This immunotherapy is an upcoming and very promising modality of treatment. I think this could be a short note in any specialty these days. So before I speak about immunotherapy, we should know about the concept of immune surveillance and immune tolerance. So our own immune system is like the police of our body. It circulates, their T cells circulate throughout our body and go and look around for any foreign bodies such as fungus, bacteria, and kill them. At the same time, there is something called the MHC, which will determine whether the particular tissue is our own or foreign. The tumor cells usually lack these things, but without this MHC, our own immune system will become more active, and that is the reason why people start to get autoimmune diseases as they age. So, how do the tumor cells hide from the immune system? How do they hide from the immune surveillance? It's called energy. For example, there are certain molecules such as PD1, PDL1, LAC3, and CTLA4. These are basically fake ID cards which a tumor may express to show that I'm a normal cell. So when the T cell comes and looks around, if you are a good cell or a bad cell, it will show a fake ID and escape from it. But when we use inhibitors against these particular molecules, then the tumor cells are exposed. So the immune system can mount a response on these things. So the side effect of immune therapy will be autoimmune diseases. So for example, this is a tumor cell here, and this is a fake ID card, which whenever a T cell comes, it will look at it and go away. But when we inhibit this, it will realize, okay, this is not a normal cell and this is going to mount an immune response against this particular thing. So in immune therapy, we're not going to cause any chemotherapy related side effects, but the side effects of immunotherapy are much different. They are more autoimmune in nature and sometimes they're quite severe. Somebody with a celiac disease may have a very bad flare-up. Somebody with interstitial lung disease may have a very bad progression to go into the ICU, and somebody may have hypophysitis, somebody may have adrenal insufficiency. And so immunotherapy, though the side effects are not as severe as chemotherapy, but they are different and sometimes can be severe. Regarding radiation therapy, what is radiation therapy? Can anybody guess? Radiation means basically a form of light, electromagnetic radiation. So when we say radiation therapy, we are specifically meaning ionizing radiation. We have ultraviolet radiation, we have visible light, we have infrared radiation, but we can't use all those things. We are using ionizing radiation. Usually they are high energy radiations in the gamma zones or high energy X-rays. Again, with X-rays, we have low energy X-rays, which are routinely used for diagnostic purposes, whereas they're in the kilovoltage range. When we're speaking about radiation therapy, they're usually in the megavolt range. They have high energy and higher penetration. So what do you mean by ionizing radiation? That means the radiation has enough energy to dislodge an electron from one of these atoms and cause a free radical. And these free radicals cause DNA damage. This is a simplistic way of saying things, but I'm sure the radiology people here would be knowing it in greater detail. So why will ionizing damage cause cell death? Free radical generation, and that leads to DNA damage and thus cell death. And again here, cancer cells may not be able to repair themselves, whereas normal cells tend to repair themselves. So classification of radiation therapy is important. We have different types of external beam radiation therapy and brachytherapy. These are the broad way of classifying radiation therapy. I'll come to brachytherapy later. For external beam radiation therapy, we have the oldest form was a telecobalt, where we use a source of cobalt-60 as a source of gamma radiation, which would emit a 1.2 mega electron volt radiation.
And tell me, please, what do you mean by Kovac concept? Brachytherapy and external beam radiotherapy and receiving support. They need to know the difference.
I'll come. So external beam radiation is called external beam because the radiation is derived from a source outside the patient. I will come to some pictures, it will explain better. So the earliest machine was a telecobalt machine, which would use a source of cobalt 60 to generate gamma energy, gamma rays, and cause therapeutic effect. These days we don't use cobalt 60 because it is hazardous to use and hazardous to discard as well. Once it is spent out, it has a half-life of about 5.5 years. After that, it has to be discarded beneath the sea somewhere. And it's not very safe. There is always a hazard that it could be misplaced or somebody could be irradiated. Whereas linear accelerators generate high energy electrons, photons, as well as protons. These are more commonly used. This can generate much higher energies compared to cobalt 60, and they are much more versatile. So this is a cobalt 60 teletherapy machine. If we look at a patient lying down, this is called teletherapy because the source of radiation is outside the patient. So all of this is gamma shielding. And here we have a small cobalt source. Why do we need all this shielding? Because we want to protect these people from them getting irradiated. When this cobalt source is made to move to this position, the radiation comes out from this, and that's going to treat the particular patient. So this is how a modern cobalt 60 machine works. The patient will lie on the couch, assuming we are treating breast cancer. The radiation is going to come from an oblique direction so that it does not go into the lungs in a tangential manner. It goes. And this is a linear accelerator. It looks like a cobalt 60 machine from the outside, but it has a much more sophisticated mechanism of X-ray generation. We can generate various energies of X-rays or various penetration and various shapes of beams and all. This is the source of X-ray. The patient is lying down here, and these are imaging devices to verify that the patient is getting radiation to where we are supposed to get it. So, for example, this lady is being treated for a pelvic malignancy, and the radiation is being delivered from here. It enters here and exits here. Then the linac is going to rotate to another direction and give some more radiation to the other direction. And overall, we are going to have a computed plan as to from which direction the radiation should get in, how much radiation needs to be delivered, how to save the normal tissues which are surrounding the tumor. All of that is possible with modern technology, and that's what we call it as intensity modulated radiation therapy. Questions?
Difference between electron, neutron, and proton. Is there any major difference or other human specific? You give electron and proton for certain cancers, neutron for certain.
Yes. Photon beam, that could be either cobalt 60 or X-ray radiation. But electron beam radiation therapies are useful only in certain circumstances. Electron beams are not very, they do not have a high penetration ability. They can be used for surface tumors, such as skin tumors. For example, somebody who has underwent a mastectomy and has a small chest wall recurrence, for whom we can use electron beam radiation therapy. Somebody who has a basal cell carcinoma on the face, for whom we deem that a resection would be very disfiguring, we can use electron beam radiation therapy. The advantage of electron beam radiation therapy is that they have very limited depth of penetration. That means we can treat superficially by sparing the deeper organs. But with photons, the depth of penetration is much higher. And that is an advantage when we are treating more deep-seated tumors. Photon beams are a totally new form of therapy, which in India is only present currently in Chennai, and Mumbai is coming up in Tata. Proton beam therapy are much more higher energy, positively charged particles. We know that photons are just packets of energy, whereas protons are actually particles. When we use very high energy protons, they cause a much higher degree of DNA damage. So there are specific characteristics of proton beams. Beyond a particular depth, they will not give any more radiation. So that's an advantage when we are treating certain sites such as skull-based tumors, spinal cord tumors, where we can treat only that particular focus and spare the remaining things. I'll come to that in the subsequent slides also. So this is a cobalt 60 beam machine. This is a linear accelerator, and this is a cyber knife. A cyberknife is actually a form of a linear accelerator. It's mounted on a robotic arm. So this is a linear accelerator, this is a robotic arm. When we look at this kind of machine, it can only rotate in one axis, whereas this can rotate in any angle, any degree, and produce a very precise beam. This is basically used for very precise radiation therapy, such as stereotactic body radiation therapy. For example, when we have a T1N0 lung cancer in a very sick patient, for example, he has an ejection fraction of 25%, he cannot be operated. For these people, we can use very high dose of radiation therapy in a very precise manner and try to get cured without the use of surgery. And certain brain tumors where we deem surgery as very dangerous or post surgery to give some boost, we can use this kind of precise radiation. But the problem is the more precise the mechanism, the more expensive it tends to get. But it's a very very good method for people with small tumors which cannot be resected for any medical reasons.
Debate about T1 lung tumors, SPRT versus surgery. And every conference we would have a debate between radiation oncologists versus surgery. And you specifically said in a patient unfit for surgery, you do SPRT. It's very consensus.
Yes, unfit or sometimes some people are extremely apprehensive about surgery, and that's all. Otherwise, surgery is still the gold standard in my opinion.
This cyberknife, does it combine both IMRT and IGRT or
it's an evolution of IGIMRT, image guided IMRT. And since the radiation is delivered in much smaller number of fractions, in like 5 to 6 fractions, it's called stereotactic radiosurgery. It's a marketing term that they use the term radiosurgery, but to be honest, it's a form of radiation therapy.
See, for the students, IGRT, IMRT is intensity modulated, where they modulate the intensity to hit the tumor hardest, and the surrounding tissues do not get much radiation. So we spare and protect the surrounding tissue. But in IGRT, what happens is you actually keep on, every day you are doing radiation, because there can be differential response to chemotherapy in a particular tumor. So some areas might have already responded. So when you see the next image, you see that the tumor has shrunk in 30. So then CT scan will tell you how to do the image. So that is the advantage. So as and when the patient is responding, to the response to the treatment. I think that is essentially what it is.
So this is what is proton beam radiotherapy. Whereas a linear accelerator requires a huge bunker, where space is a premium in many hospitals, they cannot keep it. Whereas a proton beam therapy requires an acre or more of space to be set up. Because to generate protons, you require a huge cyclotron which accelerates the particles, that requires a huge space. And that is the reason proton beam therapy tends to be so expensive even in India. For example, Apollo in Chennai has a second-hand proton therapy machine, but despite of the starting price starts from 25 lakhs per treatment. So proton beam therapy, when we look at an INAC, it looks like the same thing, but it's much larger in dimension. The treatment principles are the same. But if you look at this image here, this is proton therapy being used for somebody with nasopharyngeal cancer. So where is nasopharynx located? It's located just below the skull base. And behind the nasopharynx, if you go a bit backwards, you have the brainstem. It's a very critical organ. And slightly above the brainstem, you have the optic, slightly above the nasopharynx, you have the optic chiasm. Again, it's a very critical organ. We damage it, the patient loses vision. So when we are treating nasopharyngeal cancer, we have to treat them with at least 70 to 74 gray of radiation, without which we cannot expect a good response. And nasopharynx is not a site where surgeons can go and operate. Because once you resect all these things, they're usually involving the bone also. How do we reconstruct? It's a big problem. So this is a typical example. When we use X-ray radiation therapy, we can see this is the high red areas are the places where we see a high dose of radiation, which is actually desired in the location of the nasopharynx. The yellowish are intermediate, the blue are less dose of radiation. But again, this amount of spillage of radiation to the nearby brain is not very desirable, especially in a young patient who may suffer issues later on in life. But with the use of proton therapy, we can restrict radiation to only where we want it. That is the advantage. Again, in a child with a small glioma, use of radiation therapy to the brain has a lot of implications on the child's cognition, schooling, and other things. So when we use a standard radiation therapy, the photon beam is going to go in, target the tumor, and beyond that also there's going to be dose spillage. But proton therapy has some mechanism called as a Bragg speed. It's a concept which will take me a long time to explain, but the crux of the matter is that when we treat with proton therapy, there'll be no radiation spillage beyond the target. So the rest of the brain here is not having any radiation exposure. That is the advantage. So for example, when we have skull-based tumors, when we have spinal chordomas, you have to spare the spinal cord while treating the spinal chordoma. That is when proton beam therapy comes in very, very handy. But for the most of the other tumors, photon therapy itself suffices. And another example would be prostate cancer. Prostate is located in a situation where in the front we have the bladder, in the back we have the rectum. Use of high dose of radiation therapy can cause cystitis and proctitis, wherein again proton therapy may help avoid that, but again at the cost of very huge expense. The other way of classification of external beam radiation therapy is by the type. The oldest form was called 2D radiation therapy. Then we have three-dimensional conformal radiation therapy. 2D radiation therapy would mean the use of two fields of radiation, one from the anterior, one from the posterior, without any regard to what other structure is coming in the middle. That would lead to a lot of toxicity. 3D conformal radiation therapy would try to conform to the tumor by using various shapes of beams and various angles of beam. Intensity modulation goes a step further by trying to only confine to the area of interest while trying to spare the rest of the tissues. Then volumetric arc radiation therapy is a further refinement of IMRT in that it is faster in delivery. It is in a form of arc radiation therapy where the radiation is delivered as the linear axis is rotating in an axis. Then we have tomotherapy, which is a form of a VMAT, but the machine looks like a CT scanner. Then we have stereotactic radiosurgery and stereotactic body radiotherapy. A stereotactic radiosurgery is basically a term used for intracranial malignancies, whereas stereotactic body radiotherapy is the stereotactic surgery used for the rest of the body. So cyber knife and gamma knife were used for these things. Linear accelerators are used for the other things. So as we go higher in technology, the side effect will reduce, but the cost will go up. So when we speak about radiation therapy, it's never given a single fraction. For example, somebody is treated with radiation therapy for rectal cancer. It may, or a renal cancer, when we are definitively treating with radiation therapy and chemotherapy. The course of radiation therapy is about 5 weeks. We do not deliver entire radiation in a single day. That will be too toxic for a patient to tolerate. We fractionate radiation into smaller fractions over 1.8 to 2 grade per day, over 5 days a week, over 5 to 6 weeks. We usually give Saturday, Sunday off for the patient to recuperate. Again, why this allows better therapeutic ratio? That is, we let the normal tissue heal, whereas the tumor tissues will not be able to heal themselves.
The cycle of the cancer cells. So you coordinate with that so that you pick them while they are there.
Yes. There is a concept called as 4 R's of radiation therapy. We look at redistribution of cancer cells through the various phases of the cell cycle. For example, if I treat a particular tumor today, some of the cancer cells may be in the S phase, which is not very sensitive to radiation. Whereas some cells may be in the G2 and N phases, which are very sensitive. So those cells only get killed. The other cells will be surviving. So if you fractionate radiation over the course of period, those cells which are in the more resistant phase of cell cycle may turn over to more sensitive phase in the cell cycle, and they may also get killed. That is called as redistribution.
The reason I asked this question to the students, see, there used to be what is called as a radiation holiday, where you give them free surgical radiotherapy wait for 3 weeks or so, and then do the surgery, and then complete the radiotherapy post-operatively. There are two problems with that. One is the problem is, as the sir said, some of the cells which are resistant for radiotherapy, again, you may find them in that resistant phase. So you are not hitting them hard when you're supposed to hit them. And secondly, they may multiply and spread in that time. So then you are actually losing the battery. Second thing is the radiation. Once you disturb the tissues during surgery, for example, rectal cancer, then small bowel and things will come into the pelvis and that may unnecessarily get damaged when you do post-operative. So now the concept has gone where you complete the radiation in a go for whatever duration it is and then consider surgery. So that is the purpose of now not giving this holiday for between radiotherapy schedule.
So again, this therapeutic ratio concept is very important. That's the ratio between effect and side effect. We want better effect at the cost of less side effect. So the normal tissue should be spared, whereas the tumor tissue should not be spared. There are various fractionation schemes, as I told, 2 gray per fraction, over 35 fraction for head and neck squamous cell cancers. Hypofractionation means the using of smaller number of fractions in larger doses, like using 4 gray per fraction over 5 to 10 fractions. And stereotactic radiation uses very high doses delivered in small number of fractions, like using 20 gray into 3 fractions for early stage T1N0 peripheral lung cancers. Why we can use higher doses in stereotactic RTs? Because there's a better ability to spare normal tissues, whereas conventional RT cannot do that. This is brachytherapy. Brachytherapy is the earliest form of radiation therapy. When Madame Curie and all those people were there, they realized that radium, when implanted into tumors, will cause regressions. It was surgical implantation into a particular tumor, and looking at it, they would insert a source of radium 226 into it. It was called as manual afterloading, when you would surgically approach a tumor and place source of radiation into it for a particular amount of time and then take out the sources. Then we came in, manual afterloading was very dangerous for us radiation oncologists, because we would have to actually handle sources. Actually, even in 2009, I have myself handled iridium-192 sources, which was not the safe thing to do. But now we have remote afterloading, wherein a source of radiation is being delivered to a robotic machine called, this is the HDR brachytherapy machine. There are multiple pipes here through which there is connection to the patient. And we will go outside the room and program the machine. It's going to deliver radiation into the patient and be done with it. We'll have to only place the applicator surgically into the patient. Again, there are 3 dose rates here: high dose rate, medium dose rate, and low dose rate. I'll not go into the details here. The special advantage of brachytherapy is that we can surgically reach the planned target area and place radioactive source directly into it or near it. So we can expect it to spare the normal tissues. And the disadvantage is that it is somewhat invasive compared to external beam radiation therapy, and it cannot be used for larger areas. So this is an example of a patient with CA cervix who is undergoing brachytherapy. In cervix brachytherapy, it's quite easy because we can approach through the vagina without having to make an incision or anything. But for other sites, we may have to be more invasive, for example, prostate and other places. So here we are going to go per vaginum and place applicators. So this is the central tandem which is going into the uterus. This is the stopper here. And these 3 things will be connected to the machine which we just saw. It's going to make the source of radiation come and move through this and cause radiation to this area. This is how the radiation delivery is. So this is the rectum which is here. And this is the bladder which is here. So there is some amount of dose fall off to the bladder, but only to a small volume we are giving a high dose to the bladder. But if it was external beam radiation, all of this would have been irradiated. The same thing with the rectum. We are giving some amount of proctitis to this patient, but the prime goal is that we should treat the tumor first and then think about the toxicity. So this is the advantage of brachytherapy. We spare a large amount of bladder and rectum while treating the target with very, very high dose of radiation. So there are different types of brachytherapy. For example, esophageal cancer, we use something called as intraluminal brachytherapy, just like we do in endoscopy or raised tube insertion. We put the applicator into the esophagus and then make the radiation source pass through it. For early bronchial tumors, we have endobronchial brachytherapies, but they are not as good approach as surgery or SPRT for lung cancer.
This radium seeds is no longer used for
So radium seals are nowadays not used because the problem with radiation is that it has a very half-life of 1620 years. Once we use them, how do we discard them? There have been situations where the seeds get lost intentionally or by somebody with malicious intent. They may steal it, create a dirty device out of it, and all those things happen. That is one of the reasons every radiation a department would have a radiation safety officer who would keep track of them, but it's always a hazard. And given that it emits radon, radium emits radon as a part of its decay product. Radon is a gas, a radioactive gas. For example, if iridium decays, iridium-192 decays, it will not emit a gas. It will just decay and be done with it. For example, cobalt-60 decays into nickel, is again a metal. It will not pass anyway. But radium decays into radon, which is a gas which will go through the room and can cause hazard to anybody who can ingest it. Radon is a very dangerous thing. For example, when we look at construction sites and go with a gamma monitor, we see a very high dose of radiation because the natural radium and which is trapped within the rocks will get exposed, and that could be one of the people say that 10% of all lung cancers could be caused because of radon itself. That could be one thing.
See, students, what is one of the classical forms of brachytherapy that surgeons or surgeons refer after they don't do surgery for thyroid? Radioiodine therapy. Yeah, radioiodine therapy is again delivers very high dose of radiation only to the thyroid tissue because iodine is only picked by thyroid. Differentially, it may get excreted through the medullary quickly, but it does get picked up only by the thyroid tissue. So that's an advantage.
It's a form of radioisotope therapy where we may inject it or make the patient ingest it. We don't even have to be invasive in this situation. So these terminologies are important in this slide. Often it's never a single modality which will cure a patient. We always require multiple modalities. How do we combine different chemotherapeutic agents? When a patient breast cancer comes, use more than one agent. We don't use a single chemotherapeutic agent. That is what is called as combination chemotherapy. When we are using combination chemotherapy, we select agents in such a way that the toxicities are not overlapping. Some agent may cause severe diarrhea, some agent may cause severe neurotoxicity. But we will never combine two agents which cause severe neurotoxicity because that will be unacceptable to the patient. And then we have the methods of combining chemotherapy and radiation therapy. One way is concurrent chemoradiation therapy, when radiation and chemotherapy are given together in the same time frame. And then we have sequential chemoradiation therapy, wherein we give chemo first and then radiation, or vice versa. There are advantages of concurrent chemotherapy because there is going to be synergy when we give them together. But when we do it sequentially, we only have additive effects. Then how do we combine surgery and chemo and radiation therapy? These terminologies are important for everybody. What is the meaning of neoadjuvant? What is the meaning of adjuvant? Anybody can tell?
Neoadjuvant before the surgery, before to reducing tumor burden. After that, we do the surgery. And adjuvant therapy after the surgery, tail staging will address.
Adjuvant means addition to the
Addition to the
main modality being surgery. When we are using the term neoadjuvant, that means we are doing a supporting role, right? Supporting the surgeon by doing something before they operate. Adjuvant means we are again supporting the surgeon by doing something after the surgery to further enhance the outcomes. What is the meaning of definitive chemoradiotherapy? That means we are not thinking about surgery at all. For example, nasopharyngeal cancer. That time we are using chemo in addition to a higher dose because we know that surgery is not going to be done. That is the meaning of definitive. And again, there is another thing called as induction chemotherapy. How is it different from neoadjuvant chemotherapy? Some people use the terms interchangeably, neoadjuvant and induction chemotherapy. Induction chemotherapy again is different from neoadjuvant chemotherapy. We use the term neoadjuvant when surgery is being planned. Induction chemotherapy is sometimes when we are planning to reduce the tumor size so that we can use radiation later or bone marrow transplant later in some malignancies. When we are not using surgery as a planned thing, we are going to use the term induction, otherwise we are going to use the term neoadjuvant. And then intraoperative therapies are important. Intraoperative radiation therapy is a method. We have IORT. For example, somebody has underwent some breast MRI. We use intraoperative radiotherapy. That is also one way of treating. And then we have high-tech. I think somebody should be knowing about high-tech here. Why it is called high-tech? It could have been called IPEC. It's called HIPEC. Hyperthermic. So we are using high temperatures. I mean supraphysiological, 41 to 42. Beyond that, we are going to burn things. Below that, it's physiological temperature, anything below 41 to 42 degrees temperature is that sweet spot where there is some unfolding within the cellular DNA, and that is when they are more sensitive to the chemotherapy which is being given intraperitoneal. Again, intraperitoneal chemotherapy has limited efficacy in certain malignancies. Though we may hear a lot about it, only certain malignancies have very good efficacy. And how is it done? We can take a class about it in detail some other time.
Can you just tell us how radio sensitization works?
Yes. So radio sensitization is a concept wherein you use some chemical to enhance the effect of radiation therapy. For example, one form of radio sensitization is to use concurrent chemotherapy. The other form of radio sensitization is to use hyperbaric oxygen therapy, because oxygen sensitizes to radiation therapy by causing more free radicals, which are basically oxygen radicals. And the other way is to use oxymimetic agents such as metronidazole is basically radio sensitizer. We have misonidazole, nimorozole. Though they were theoretically very attractive, these days practically we find that concurrent chemo is more effective than use of radio sensitizers. And then on the other end of the spectrum, we have radioprotectives such as amifostine. For example, somebody who is undergoing high dose radiation therapy to the prostate, we may use some intrarectal amifostine suppositories to protect them from radiation toxicity. But again, when you use radioprotectants, you could also be protecting the tumor, which is very good.
Other thing that is about neoadjuvant chemotherapy or chemoradiation, which many people discount is the fact that once the tumor is of a certain size, there will be micro emboli, micro metastasis everywhere. So when doing surgery at that stage, even if it's some of the tumors may be operated, and then in subsequent delay in the treatment because either the patient will take time to recover from surgery or the complications which may hinder beginning chemotherapy. So we give more adjuvant, so we are giving those, early metastatic disease as well. Coming from rendering tumor which is currently not very clear. That's another advantage.
The other classification of chemo and radiation is treatment philosophy. I think even in surgery, the concept will come in. Radical and palliative. Radical, where we are trying to cure a patient, even at the expense of some sort of toxicity. When we are treating somebody radically, we are accepting some toxicity, yes, because it's a price to pay for somebody who is likely to be cured. But when we know that somebody is not going to be cured, causing toxicity is not acceptable. That's when palliative treatment philosophy will come in. Now, that was a brief explanation of chemo and radiation. If anybody wants things in more details, we will come to it in a different class. For example, if there is a specific topic which anybody wants, we have much more slides. We will take the questions in the last. So there are a few real examples. Now, there is a small game here. Let's see who will answer it well. There are like some 10 cases. If anybody gives the good more than one correct answers, we are going to note them and they will have a prize. So patient with CA cervix stage 1A1, very early stage. What is the ideal treatment? Raise your hand, I will give the option. We don't have any gynecology residents here, otherwise they would have told. See, hysterectomy, if you say you are not a surgeon, you should say what kind of hysterectomy? What simple, we will pull it out, vaginal hysterectomy will do. What do you mean by hysterectomy? You should speak to a, speak like a surgeon. Which type of hysterectomy?
Actually, say A cervical cancer. The problem is give the example of power. Correct? Yeah, same number.
So in this situation, we have to approach it this way. Is fertility preservation required? Is the lady young? Then we will do trachelectomy. We are not going to remove the entire uterus. We are going to try and remove only the tumor. Otherwise, we do radical hysterectomy versus radical radiation therapy. We will not require chemotherapy. Both of them have an equivalent outcome in this situation. But the problem with radical radiation therapy is going to knock out fertility. So the next question is cervix stage 2B. It's technically locally advanced. So what do we do? The standard of care. Concurrent chemoradiation therapy, wherein we treat weekly cisplatin for 5 weeks along with radiation therapy. During the course of radiation therapy, once a week we give chemotherapy, and every 5 days a week we are going to give radiation therapy for 5 weeks. After a couple of weeks, we are going to do intracavitary brachytherapy, because we cannot give more than 45 to 50 gray of radiation by external beam, because we are going to burn up the bladder and rectum. So we are going to give 45 to 50 gray, which is the tolerance dose for small bowel. Beyond that, we can't give external beam radiation therapy. But the cervix cancer requires 70 to 80 gray for it to be eradicated. So what do we do then? We are going to use brachytherapy to boost it. This is how we approach it. And the concept is that we should complete treatment within 2 months of starting treatment. That is when we have 80 to 80% cure rates in this stage of cervix cancer. Now another example, cervix cancer stage 4B, that is metastatic disease. Who said palliative? You are 10 years behind in time. You should always look at the patient. If the patient is oligometastatic or the patient has disseminated metastasis. What if the patient has only one single metastasis in one part in the liver? Patient is potentially, I know the chance of cure is less, but not as bad as a patient with disseminated metastasis. Stage 4B is always never to be considered as a single entity. Somebody may have polymetastatic disease, somebody may have oligo. Oligo means few. Less than 5 metastasis, we technically call them as oligometastasis. So in oligometastatic cervix cancer, usually these people are not very old, they're 35, 40-year-old ladies. How do we should not think of just abandoning them. So we use chemotherapy and radiation therapy, and focal therapies may be used with stereotactic radiation therapy if there's a single lesion in the liver, or try to resect if it's a peripheral lesion in the liver. And we also combine immunotherapy in this situation, wherein we have seen very 20-30% of people actually get cured also. For disseminated patients, yes, then the treatment intention becomes palliative. The dose of chemotherapy will become somewhat lower, because we don't want them to suffer toxicity in the last days of their life. The goal is to maintain quality of life and to improve the duration of their life. Like somebody who may otherwise live for 6 weeks, we may try and make them be alive for 1 or 2 years. It may be meaningful for somebody who may have some pending tasks in their life. Many people may have marriage of the child coming up, they want to be alive within the time. You can help them to do that. Again, we use bevacizumab along with chemotherapy to enhance the duration of response. Sometimes we use immunotherapy. Carcinoma of the nasopharynx stage 4A. What do we do? I already gave a hint. Radiotherapy alone won't be enough because the stage is quite big. So we can assume there is going to be some amount of microscopic disease elsewhere. So we are going to use concurrent chemoradiation therapy, once a week of cisplatin along with 6 to 7 weeks of radiation therapy, followed by adjuvant radiation, chemotherapy. After chemoradiotherapy is over, we give 3 more cycles of chemotherapy to finish the task, because there could be microscopic disease which may be in the systemic circulation, which has to be tackled. That is the principle here. Now, this is simple. See a buccal mucosa, stage T1, N0, N0. Who said surgery? What do you mean by surgery? More specifically. And what else do you do? See, wide local excision is fine. How do you address the neck? Do you do any specific neck dissection or not? T1, N0. N0 is clinical, ma. We don't know. It's not pathological T1 and 0. A very hefty person with big neck, you will not find lymph nodes. What do we do? We assume it's T1 and leave it like that. We may actually try and avoid radiation therapy. It's very toxic in the face to give radiation therapy. So we want a proper surgery to be done so that we don't require it. Yes. What are the lymph node lymph node stations you are going to address? This is well lateralized buccal mucosa. I'm not speaking about a midline tongue or something, then it becomes more complex. Well lateralized buccal mucosal tumor. So, and other things, the main thing is we'll rely on the surgeon to give us a proper PTNM stage. Based on that, we'll decide whether further treatment from my side is required or not. So we look at a lot of factors other than the PTNM stage. We look at the depth of invasion. This is very important, oral cancers. The margin status, it's a proper margin, R1 margin, R0 margin, all that we are going to see. Now, this is C, a buccal mucosa stage 4C. What does stage 4C mean? Distant metastasis. 4A means locally advanced, distant metastasis. So, in this situation, we use chemotherapy along with immunotherapy. The standard of care is to use pembrolizumab immunotherapy, but unfortunately, it's extremely expensive in India. It costs like 4 lakhs per month. But we Indian people do jugaad, and we use nivolumab at a much lower doses and get similar results. Like we use 40 mg of nivolumab, which costs only 40,000. And I personally have it with people who have been cured in this state also. And the other alternative is to use anti-GFR monoclonal antibodies. The problem with immunotherapy is that it takes time for you to get some response. The median time for you to get effect or side effect is 3 months. Once you start immunotherapy, patient will keep asking where there is no response, there is no response. Because it takes time for the immune system to get primed and go and mount the response. Actually, you are going to see pseudo progression in the initial few days. A tumor of 2 by 2 centimeter size, when you start immunotherapy, all the immune cells will go and infiltrate into the tumor. So when you do an image too early, you will see that the size is 2.5 by 2.5. It's called pseudo progression. It should not be panicking. So you should never do imaging at least 3 months before you start immunotherapy, or else you get pseudo progression and everybody will panic. They'll suddenly start making course corrections and you lose the chance of curing. And the advantage of anti-GFR monoclonal antibody is that it is going to give you a quicker response, but the responses are usually not sustained. Immunotherapy has a phenomenon called as a tail phenomenon. If you look at the survival curve of immunotherapy, there is something called as a tail, very plateaus. That means some 20% of people who are treated with stage 4 disease with immunotherapy tend to be cured. Whereas with other therapies, you get partial responses, you rarely get permanent cures. So this is a very important question for everybody here. How do you address this situation? I want surgery residence somebody else. Anal canal, clinical T2N1. What is the approach? If it was a rectal, it would be different, I know, but in anal cancer. Okay, nobody will get any question. Negros regimen. It was one of the classical regimen from the Wayne State University. They found that the use of chemotherapy along with mitomycin in private, this was a 40-50-year-old data, and it has still not been surpassed. For squamous cell carcinoma, one thing about anal cancers, they are usually squamous cell cancers. And they do very well with concurrent chemoradiation therapy, mitomycin 5-FU with radiation therapy. And the regimen was so effective that even now we are scared to deviate from it. Although we have better agents, mitomycin is quite an old agent. We have capstabine, we have many other agents, but we feel the response is so good, why not stick to that? So this is an example wherein you give definitive chemoradiation. I'm not speaking new adjuvant, definitive. You're trying to use it as a sole modality, complete chemoradiation, and be done with it. After 6 weeks, you're going to see the response. If there is residual, then comes in the question of operating. The problem with operating renal cancers is that the patient will be left with what? And the other problem is N1. It could also mean that there will be need for inguinal dissection, is again a morbid procedure. This is simple. Stage 2 seminoma. Never say orchidectomy. You should say what? High inguinal orchidectomy and which lymph node? What inguinal? Which is the landing site for seminoma? What is the meaning of landing site for seminoma? See, where is the testicular origin from the embryonic stage? Mesonephros, you know all those concepts, no? When near the kidney they are located, then they gradually descend and go into the scrotum. So the lymphatics are still retained there, near the renal hilum. So the first landing site is there, and then you will get lymph nodes in elsewhere. If inguinal lymph nodes are there, that is very bad. That means somebody has a throttle violation or something else. So this can be approached in various ways. One way is to do surgery. For stage 2, will require 3 cycles of BEP regimen or 4 cycles of EP regimen. E means bleomycin. It's quite a toxic drug. We try to avoid it when possible, but when we avoid BEP, we have to give 1 more cycle of EP. That is, they are considered equivalent. After surgery, the other option is to do radiation therapy. And platinum, cisplatin. The other option is to use radiation therapy by avoiding chemotherapy. But either way, in a young man with seminoma, there are some things to be kept in mind. One is erectile dysfunction, which could happen with a RPLND. Some people do nerve sparing RPLND, but we cannot guarantee that there is going to be no erectile dysfunction. But radiation therapy again has its advantages. It's a local regional therapy. It will not take care of any microscopic disease which is in the lung. So we use chemotherapy in this situation. This is a different situation. Same stage, but it's a non-seminoma, it is germ cell tumor. Let's say it is seminoma. What do we do? Man with NSGCT stage 2, not stage seminoma. Same stage. How will you approach? Your initial approach will be the same. High inguinal orchidectomy followed by BEP chemotherapy. Here, we don't have the option of radiation therapy because seminomas are radiosensitive, whereas non-seminomas are not very radiosensitive. The other option is nerve sparing RPLND, which some people do with equivalent responses. But the problem when we do a nerve sparing RPLND, you will not be giving chemotherapy, and so microscopic disease elsewhere has a higher risk of relapse. What do we do in this situation? Anaplastic CA thyroid. Not papillary, not follicular. I'm saying anaplastic CA. Nothing. 6 months is a huge time, huh? We will never say that. So when a patient with anaplastic CA thyroid comes, you should try palliation at least. What is the main problem? It's a big mass sitting and compressing the trachea. At least let them breathe. Okay. For palliation, if not for cure. And then external radiation therapy can be another palliative measure. Chemotherapy can be used for palliation. And immunotherapy is also something you can use for palliation. At this point, I have to say that sometimes there are situations where things go outside the norm. We treat palliatively, there are people who get cured also. That has happened with me once. Sometimes we do get lucky, so we should never say nothing. Try to offer something, comfort them, do something. If they themselves don't want anything, then fine. This is another easy question for you. Clinical T2 and 0 postmenopausal ER positive, HER2 negative breast cancer. What do we do? How do we approach? MRM always. See, you should always note where the tumor is, which location is it, is a well lateralized location, central, just below the nipple. So you cannot just say MRM just like that. Just because she's postmenopausal does not mean that she does not want her breast. So the main goal here is surgery followed by hormonal therapy. If MRM is done, then I will not require to give radiation therapy because it's only T2 and 0. And if the pathological stage also confirms T2 and 0, I will not require to give radiation therapy. If breast conservation surgery is done, then we will require to give radiation. Okay. And again, in this early stage, I may not give chemotherapy. We may do with hormonal therapy alone. Now, this is a different situation. Same stage, but premenopausal lady with triple negative breast cancer. What do we do? Why are you so keen on MRM? Huh? Premenopausal lady. Do you want to start off with BCS initially? Say triple negative breast cancer is much different from other types of breast cancer. It's more of a systemic disease. It behaves more like a lymphoma rather than a carcinoma. It's very aggressive in the initial couple of years. If you take care of them for the initial 2-3 years, if they don't relapse, they will never relapse. Whereas hormonal positive breast cancer, somebody treated in 1984 can relapse now also. So I have mentioned surgery followed by chemotherapy, but I would also argue that neoadjuvant chemotherapy followed by surgery or BCS with radiation therapy is also equally good. We'll also have to look for BRCA mutation since it's premenopausal with triple negative breast cancer. This is a premenopausal lady with ER positive, HER2 positive with clinical T4C N2. What is T4C? So clinical T4C and N2. Premenopausal. How do you start? What do we do as neoadjuvant therapy? Is also HER2 positive. What neoadjuvant regimen do you prefer? Latin is. So here the neoadjuvant regimen would be TCHP, taxane, carboplatin. H means ratuximab, E means pertuzumab. But the problem with pertuzumab is its cost. It's still patented by the American company. We many times use TCH, which is still a very effective regimen. 6 cycles of TCH and then surgery. So before we start neoadjuvant chemotherapy, we do something. What is that? Yes, we place clips. So that in case there is a complete response, the surgeon should later know where the tumor was. That's why. So after surgery, then we will do radiation therapy is also required for her. And then she will require hormonal therapy and HER2 therapy for a year. Yes. No. Ideally, we should give 6 cycles because there are some biological reasons as to why we don't want to interrupt chemotherapy or radiotherapy. Assume there are 100 cancer cells. You give 1 chemo cycle, 10 will die, 90 are remaining. Another cycle, you give 20 are dead. So after third cycle, 50% of cancer cells are dead. So what about those 50% of cancer cells which are not dead after 3 cycles of chemotherapy? That means they were resistant. And if you give them time by operating, those cells can proliferate and reform a new tumor which is resistant to the previous use. We have to give the therapy. all six. And only when there is progression during the initial couple of cycles, that means it is clearly not responding, then we panic and go ahead with surgery. That's how it is. Usually they do respond. This another situation, clear cell renal cancer, clinical T1N0. Good, one question somebody answered. Again, after that, we'll only observe its early stage. This is a different situation. Clear cell renal CA, clinical T3, N0, but lung mets. What is the prognosis for this patient? Very bad. Huh? It's not that bad actually. They do well for a long time. So surgery, we still prefer debulking surgery whenever feasible, and then immunotherapy, and then anti-angiogenic therapy with curative intent. Many people do well for many years. Now, clear cell renal CA, but this time the metastasis in the brain. What do we do? We have to look at how many brain metastases are there. A solitary metastasis in the frontal bone can be removed off. But if something situated in the insular region or in a critical brainstem region, then it cannot be resected. So we have to consider stereotactic radiation therapy to the brain metastasis, surgery to the primary tumor if feasible, and then immunotherapy and anti-angiogenic therapy. Again, they have a very good prognosis. This everybody should answer. Rectal cancer, lower 1/3, clinical T3 and 1. I think Sania should not answer, only the resident should answer. See, it's not so simple. Surgery is a part of treatment, I agree, but the answer should be much more nuanced. Sir actually just now spoke about something called as total neoadjuvant therapy. I specifically mentioned lower 1/3. All right. So the philosophy is called total neoadjuvant therapy. Earlier we would think about surgery, think about some course of radiation therapy, then surgery, and then further chemotherapy. That would be very toxic because somebody in the post-operative period to undergo chemotherapy is almost never possible. We either do a lot of dose reductions, which again reduces efficacy. So in this situation, total neoadjuvant therapy with both chemotherapy and radiation therapy. Like for example, we start with long course chemoradiation, then 2-3 cycles of capox regimen, then do a PET CT. And MRI is required for the surgeons because they have to look at the planes of surgery. Then go ahead. And yes, sometimes we may not be able to spare the skin, then what to do? We have to spare the life. So total neoadjuvant, the reason why we call total is because all non-surgical therapies planned prior to surgery. This stage 3 non-Hodgkin's lymphoma. What is the role of surgery here? Surgeons are still involved. We will require an excision biopsy. We should never do a core biopsy in lymphoma because we need the nodal architecture to exactly say which kind of lymphoma it is. So rituximab plus CHOP chemotherapy regimen, cyclophosphamide, doxorubicin, vincristine, and prednisolone regimen. And since it is stage 3, we will also require CNS prophylaxis because these chemotherapeutic agents will not cross the blood-brain barrier. We have to use either high-dose methotrexate or intrathecal chemotherapy. For Hodgkin's lymphoma stage 3, how different is the treatment? Stage 3 means you have disease above and below the diaphragm. Again, some excision biopsy is required to ascertain which type of Hodgkin's, classical, NLPHL. For NLPHL, you treat it like a non-Hodgkin lymphoma. But for a classical Hodgkin lymphoma, you're going to use the ABVD regimen versus the BACOP regimen, followed by use of radiation therapy to residual foci of disease or to sites of initial bulky disease. Multiple myeloma. Here we may not require surgery except for spine fixation in case the spine is already broken. So we do something called an induction chemotherapy. We are going to use lenalidomide, bortezomib, dexamethasone, followed by consolidation with autologous hematopoietic stem cell transplant, which is also something called as autologous bone marrow transplant. Prostate cancer stage 4 de novo with extensive bone mets. What do we do? Already sir has discussed this. Stage 4. Prognosis is not very bad. They will somebody 75, they may live till 85 also. Yes, hormonal. And I'm sorry I mentioned oophorectomy, should have been orchidectomy. Hormonal therapy in the form of orchidectomy, medical versus surgical orchidectomy. Then abiraterone, which is steroid synthesis inhibitor. Zoledronic acid is required because there are bone mets to prevent bone breakdowns. Basically, say bisphosphonate, which takes in calcium from peripheral blood and goes and puts it like a cement into the bones, so that the osteoclast cannot eat into the bones. Then we may also require chemotherapy or radiotherapy. So I think it was a long class for everybody, but any specific questions? Or if any specific class is required, we can schedule it later.
Nobody has any questions? I like to thank Swaroop for excellent introductory lecture on chemotherapy and radiotherapy. The main thing we all have to understand is even at the planning stage, once you have seen a patient with any tumor, involve the medical oncologist, radiation oncologist, as the case may be, in the form of a tumor board or a multidisciplinary team meeting to plan the treatment properly so that they are all aware and involved even from the beginning. That is very important. Okay, thank you.